Welcome to another episode from the Veterinary Medicine Digest. Today we are embarking on an extensive exploration of one of the most challenging and rare corners of canine endocrinology, the diagnosis and surgical treatment of hypersomatotropism in a diabetic dog, using the technique of transsphenoidal hypophysectomy. While many clinicians are intimately familiar with the more common pituitary disturbances in our canine patients, such as the corticotroph adenomas that drive pituitary-dependent hypercortisolism, the occurrence of a primary growth hormone secreting tumour in a dog remains a clinical rarity that demands a high level of diagnostic precision and surgical expertise. To truly understand the significance of this procedure, we must first look at the broader landscape of pituitary pathology in companion animals, and how the lessons learned from both common conditions and feline medicine have shaped the current surgical standards. The pituitary gland, or the hypophysis cerebri, serves as the central command center of the endocrine system, controlling fundamental biological processes ranging from metabolism and reproduction to growth and the stress response. In the dog, the gland is composed of the adenohypophysis, which includes the anterior and intermediate lobes, and the neurohypophysis, which forms the posterior lobe. During embryonic development, the adenohypophysis arises from an invagination of the oral ectoderm known as Rathke's pouch, which eventually separates from the oral cavity to reside within the sella turcica of the sphenoid bone. Within the pars distalis of the anterior lobe, 5 distinct hormone-secreting cell types differentiate under the influence of lineage-specific transcription factors. The corticotroph cells, which secrete adrenocorticotropic hormone, and the melanotroph cells of the intermediate lobe, which secrete alpha-melanocyte-stimulating hormone, both fall under the lineage governed by the T-box transcription factor, TBX19, also known as TPIT. In contrast, the thyrotroph cells secreting thyroid-stimulating hormone, the lactotroph cells secreting prolactin, and the somatotroph cells secreting growth hormone are all derived from the pituitary-specific positive transcription factor 1 lineage. In dogs, the vast majority of functional pituitary tumours are corticotroph adenomas of the TP lineage, which result in the clinical syndrome of hypercortisolism or Cushing's disease. It is estimated that 1 in every 500 dogs develops this disorder, making it a cornerstone of veterinary internal medicine. However, when we turn our gaze toward the somatotrophs and the condition of hypersomatotropism, we find a starkly different epidemiological profile compared to our feline patients. In cats, somatotroph adenomas are the most common form of pituitary neoplasia, frequently resulting in secondary insulin-resistant diabetes mellitus and the physical features of acromegaly, which include soft tissue, overgrowth, and organomegaly. In the dog, however, hypersomatotropism is most commonly not a result of a pituitary tumour at all. Instead, it is typically an extra-pituitary phenomenon driven by progesterone. This can occur during the luteal phase of the estrous cycle in intact bitches, or following the administration of exogenous progestagens, which stimulates the mammary gland to produce growth hormone that then enters the systemic circulation. Another fascinating mechanism for canine growth hormone excess involves the functional adaptation of the pituitary gland during primary hypothyroidism. Research has shown that prolonged thyroid hormone deficiency leads to a loss of the normal negative feedback loop, causing massive thyrotroph hyperplasia as the gland attempts to compensate. More remarkably, dogs in a hypothyroid state can exhibit transdifferentiation, where cells of one lineage transform into another to meet functional demands. Specifically, somatotrophs may transform into thyrosomatotroph or thyroid deficiency cells that are bihormonal, staining positive for both growth hormone and thyroid-stimulating hormone. This unique canine phenomenon explains why hypothyroid dogs often exhibit elevated basal growth hormone concentrations and a paradoxical growth hormone response to the administration of thyrotropin-releasing hormone. Despite these more common causes, primary somatotroph adenomas of the pituitary gland do occur sporadically in dogs, representing a significant diagnostic and therapeutic challenge. To date, only a handful of cases have been documented in the literature where excessive growth hormone secretion was definitively traced back to a functional pituitary tumour rather than the mammary gland or a hypothyroid state. These dogs typically present with a combination of insulin-resistant diabetes mellitus and acromegalic physical changes, such as gingival hyperplasia, widened interdental spaces, macroglossia, and a characteristic inspiratory stridor caused by soft tissue thickening in the upper respiratory tract. When faced with a pituitary mass and clinical evidence of hormonal hypersecretion, the gold standard for definitive treatment in human medicine has long been transsphenoidal surgery. This approach was reintroduced and refined for the dog at Utrecht University in the early 1990s, primarily as a treatment for pituitary-dependent hypercortisolism. Over a 20-year period, surgeons there performed transphenoidal hypophysectomy on more than 300 dogs, providing a wealth of data on outcomes and prognostic factors. A critical metric developed through this work is the pituitary height to brain area ratio, which allows for a standardized assessment of pituitary size regardless of the dog's skull dimensions. A ratio greater than 0.31 is considered indicative of pituitary enlargement in dogs, and studies have confirmed that larger tumour size at the time of surgery is negatively correlated with survival time and the duration of the disease-free interval. The successful application of hypophysectomy in cats with hypersomatotropism further emboldened the veterinary community to pursue surgical options for rare canine somatotropinomas. In large cohorts of cats, hypophysectomy has demonstrated remarkable efficacy, with survival rates around 85% and diabetic remission rates as high as 92% in some studies. These feline patients often show a rapid normalization of insulin-like growth factor 1 concentrations and a near-immediate reduction in insulin requirements after the growth hormone-secreting mass is removed. The question then became whether the dog, with its unique metabolic background, would respond with similar vigor to the surgical elimination of growth hormone excess. This brings us to our primary case study, a deep dive into the treatment of a 10-year-old neutered male Staffordshire Bull Terrier that presented with uncontrolled diabetes mellitus and features suggestive of acromegaly. The dog exhibited classic clinical signs, including polyuria, polydipsia, weight loss, and exercise intolerance, but it was the progressive inspiratory, stridor, and the widening of the interdental spaces that pointed toward a more complex underlying endocrinopathy. Initial diagnostics confirmed a severe hyperglycemia of 30 millimoles per litre and a fructosamine level of 658 micromoles per litre, which remained poorly controlled despite escalating doses of lente insulin up to 2 units per kilogram twice daily. This profound insulin resistance prompted the measurement of serum insulin like growth factor 1, which was found to be markedly elevated at 1,214 nanograms per milliliter, well above the reference interval of 42 to 449 nanograms per milliliter. To confirm that this growth hormone excess was originating from the pituitary and was not associated with other conditions, a comprehensive workup was required. Hypercortisolism was systematically ruled out using 2 normal basal urinary corticoid to creatinine ratios and a normal suppression of serum cortisol in a low-dose dexamethasone suppression test. Thyroid function was also confirmed to be within the normal range, eliminating hypothyroidism as the cause of the growth hormone elevation. Furthermore, the dog's history revealed no exposure to progestins, and the abdominal ultrasound showed no evidence of mammary tissue pathology, effectively ruling out the mammary gland as the source. A somatostatin suppression test was performed to characterize the growth hormone secretion further. In a healthy dog, the administration of somatostatin should inhibit growth hormone release, but in this patient, the concentrations remained persistently elevated above 10 nanograms per milliliter, providing functional evidence of a somatotroph adenoma. Advanced imaging with magnetic resonance imaging and contrast-enhanced computed tomography revealed a well-defined pituitary mass measuring 13 by 11 millimeters, which extended into the dorsal suprasellar region and exerted a mild mass effect on the thalamus. The calculated pituitary height to brain area ratio was 0.69, significantly higher than the 0.31 threshold for enlargement. The computed tomography also identified secondary systemic changes typical of chronic hypersomatotropism, including hepatomegaly and marked osteoarthritis in the elbows and shoulders, which may have been a reflection of long-term exposure to the growth-promoting effects of insulin like growth factor 1. With the diagnosis of a pituitary somatotroph adenoma firmly established, the clinical team at Utrecht University proceeded with transsphenoidal hypophysectomy. The surgical approach is a meticulous procedure that requires precise anatomical planning, often utilizing three-dimensional reconstructions of the skull to localize the burr hole in the sphenoid bone. After incising and retracting the soft palate, the surgeon encountered a mucoperiosteum that was thicker than what is typically seen in dogs with Cushing's disease, covered by thick folds of tissue that were characteristic of the acromegalic state. Access to the pituitary fossa was gained through the 10 mm thick sphenoid bone using an electrically powered burr. Once the dura mater was coagulated and incised, a stark white pituitary adenoma was revealed. The surgeon carefully detached the mass from the fossa, and the completeness of the removal was assessed by visualizing the entrance to the third ventricle and confirming an empty fossa with a ball-tipped probe. The immediate post-operative results were biologically encouraging. Elevated plasma growth hormone concentrations, which had been 52 nanograms per milliliter before surgery, rapidly declined to 7.6 nanograms per milliliter within 5 hours. Serum insulin, like growth factor 1 concentrations, which have a longer half-life of hours compared to the minutes for growth hormone, normalized within the first week post-operatively. Histopathological examination of the excised tissue confirmed the diagnosis of a growth hormone-producing eosinophilic pituitary adenoma, with immunohistochemistry showing strong cytoplasmic staining for growth hormone in the majority of the neoplastic cells and no immunoactivity for adrenocorticotropic hormone. However, the clinical course that followed highlight the significant differences between canine and feline responses to this procedure. In cats with hypersomatotropism, the immediate reduction in growth hormone often leads to a sudden resumption of insulin sensitivity, allowing for the rapid tapering and often complete discontinuation of insulin therapy within days. In this Staffordshire Bull Terrier, managing the blood glucose levels remained an arduous task. Following surgery, the dog remained persistently hyperglycemic, and the insulin dose had to be increased significantly to achieve even unsatisfactory control. The team experimented with different insulin types, moving from lente to protamine zinc insulin, and eventually to a shorter-acting human insulin administered 3 times daily, which finally provided some stabilization. At the 6.5-month follow-up mark, despite the fact that the dog remained in remission for hypersomatotropism with a normal insulin-like growth factor 1 concentration of 295 nanograms per milliliter, the diabetes mellitus remained poorly controlled. The dog had gained a significant 15 kilograms of weight over 2 months and was exhibiting reduced mobility and persistent hunger. This outcome presents a sharp contrast to the high success rates seen in our feline patients. In cats, the pancreatic beta cells appear to retain a remarkable capacity for functional recovery even after long periods of glucose toxicity and growth hormone antagonism. In dogs, however, the damage inflicted by chronic growth hormone excess and secondary diabetes mellitus appears much more refractory. Historically, dogs that develop diabetes mellitus secondary to hypercortisolism often exhibit irreversible beta cell dysfunction, and this case suggests that somatotropinoma-associated diabetes follows a similar pattern of permanent peripheral insulin resistance and beta cell exhaustion. The authors of the study hypothesize that this difference might be related to species-specific genetic factors and the differing nutritional backgrounds of the 2 species, with dogs being mixed omnivore carnivores while cats are strict carnivores. The persistent hunger and massive weight gain in the post-operative period further complicated the management, creating a vicious cycle of obesity and insulin resistance that ultimately compromised the dog's quality of life. After 286 days of intensive post-operative care, the owners elected for euthanasia due to the difficulty in maintaining the dog at a comfortable level. This case provides a sobering perspective on the goals of surgery for canine hypersomatotropism. While transphenoidal hypophysectomy is an exceptionally effective tool for achieving biochemical remission and removing the physical mass of the tumour, it is not a guaranteed cure for the secondary diabetes mellitus in dogs as it is in cats. This distinction is vital for clinicians to discuss with owners during the pre-operative planning phase. We must also consider alternative medical therapies for cases where surgery is not an option or is adjunctive treatment. For example, recent case reports have explored the use of the dopamine agonist cabergoline in dogs with hypersomatotropism. In one instance, a 12-year-old Labrador retriever was diagnosed with a rare functional plurihormonal pituitary adenoma that co-expressed both growth hormone and adrenocorticotropic hormone. Treatment with cabergoline initially led to a decrease in circulating concentrations of both hormones and a notable reduction in acromegalic soft tissue overgrowth. However, the efficacy was short-lived, with hormone concentrations and clinical signs returning to baseline after 7 months, likely due to the development of drug resistance or low dopamine receptor density within the macroadenoma. Other medical options, such as the multi-receptor somatostatin analog pasireotide, have shown some promise in both dogs and cats by targeting the somatostatin receptors on the tumour cells. In one canine case, combined treatment with radiotherapy and pasireotide led to a resolution of acromegalic signs and even diabetic remission, suggesting that targeting somatostatin receptors 2 and 5 might be more effective than dopamine receptor agonism in somatotropinomas. Nevertheless, the exorbitant cost and limited availability of such medications remain significant barriers to their widespread use in veterinary practice. The deep dive into this surgical case underscores the multifaceted nature of pituitary disease. It teaches us that the one-cell, one-hormone concept is often too restrictive, as evidenced by the transdifferentiation seen in hypothyroid dogs and the monomorphic plurihormonal adenomas that can secrete both growth hormone and adrenocorticotropic hormone. It also highlights the importance of standardized imaging metrics like the pituitary height to brain area ratio in predicting surgical difficulty and long-term outcomes. For the Staffordshire Bull Terrier in our main case, the surgery was a success from a technical and biochemical standpoint, yet the underlying metabolic damage proved insurmountable. As we move forward, the veterinary community continues to refine these techniques and expand our understanding of species-specific responses to endocrine intervention. The lessons from the Utrecht cohort and the emerging case reports of canine somatotropinomas remind us that every patient is a complex biological system where the resolution of a primary hormonal excess is only one part of the journey toward recovery. The persistent insulin dependency in this dog serves as a powerful reminder of the delicate and sometimes fragile nature of the canine pancreatic beta cell when compared to its feline counterpart. In closing, the treatment of canine hypersomatotropism by transphenoidal hypophysectomy represents a pinnacle of neurosurgical and endocrinological achievement in veterinary medicine. It requires a dedicated team of specialists, including endocrinologists, neurosurgeons, and critical care experts, to navigate the intensive preoperative, stabilization, the precision of the intracranial approach, and the complex post-operative hormone substitution protocols. While the path to a full clinical cure for the diabetic state in these dogs remains challenging, each case, like the one we discussed today, provides invaluable data that moves us closer to more effective management strategies for our canine patients. Thank you for listening. The titles for the referenced papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light and tails wagging.